All right, we're gonna give everyone a couple of minutes to come in from the waiting room. Thank you everyone for joining us. See, I think we can get started. Are you still seeing my screen or did it go away? I think it went away.
No, I was still seeing it.
Oh, it lied to me. All right, let's try that again. All right, welcome everyone officially to our webinar, the latest KDIGO guidelines for IgA nephropathy. My name is Isela Delgado. I'm the Director of Brand Creative for the IgA Nephropathy Foundation. I'd like to thank Dr. Chevalier for taking the time to be with us this evening. And I also want to make sure we thank our sponsors for helping us bring this webinar to you, Calliditas, Novartis, and Vertex. Without their support, we would not be able to do programming like this. So thank you very much. And then before we officially get started and dive right into the presentation, I just wanted to make two quick announcements on behalf of the foundation. Let's see if this will let me click here. We're going to go, my screen just paused up. So one is I want to make sure that everyone is aware of the IgAN Hope patient registry. This is a patient registry that the foundation launched in July of last summer. And the whole purpose and goal of this registry is so that we can make sure that the patient voice, your voice, stays at the center of research, not just for one specific study or one specific trial, but for us to really understand and gather some insights on how we can change the future of IgA nephropathy treatment. The website is IgANHope.org. We are recruiting worldwide, so no matter where you are, you can participate. What does participation look like? It is a longitudinal study where you are just providing your patient experience over time. It's really easy to sign up. There's a QR code here. You can also go to IgANHope.org. But you're just going to complete the consent process. It takes about 15 to 20 minutes. Answer some questions about your labs. My dog is not happy about me talking right now. If you can hear her barking in the background, sorry. There's no right or wrong answers. This is really about you sharing with us how you're feeling and how everything is going with you over time. And then we are sharing this data in a report so you can kind of see um, what the collective journey feels like for IgA nephropathy patients now not just across the country, but across the world. So symptoms that you maybe felt at one time where you felt like you were the only one who experienced that. We're putting that all together and we just shared some valuable insights and I'll make sure to share that as a recap to all of those for you that have attended this call. The other event that I want to make sure or announcement that I want to bring to everyone's attention is our annual conference. It is the only gathering of IgA nephropathy patients and caregivers in the world. And we're really excited for Spark this year. It is going to be held in Atlanta, Georgia. Spark, the whole name comes from the fact of when you're in a room with other people who get it, something feels magical. And for anyone who's been to Spark, if you want to share in the chat, if you want to try to recruit someone, we create an influencer strategy here. I promise you, you'll come, you'll be informed, you're going to be educated, but you're going to leave with friends. You're going to leave with becoming a better advocate, not only for yourself, but for other people's with IgA nephropathy. Um, I also want to make sure that people understand that there is no barriers to getting to Spark, hopefully, in terms of costs. We do offer financial assistance through one of our sponsors. So please look into it, iganspark.org. We are at 80% capacity currently, but we want to make sure that we encourage as many people as possible to join. And if you have any questions about Spark or IgAN Hope, you can drop those in the chat. Also, I'll be monitoring the chat during this call, and I think I have spoken for way too long, and we are ready to get started. I will put myself on mute and hide myself, and hand over the keys to Dr. Chevalier, and you can do all the talking. But please, as questions come up, please drop them in the chat. We want this to be interactive. It is very hard to be on this side and only talk to silence. So please drop your questions in the chat, and we'll keep this as interactive as possible.
Thanks, Gisela. I'm just going to share my screen.
You got it.
All right, so my name is Jim Chevalier. I'm one of the nephrologists here in New York City. I do specialize in both polycystic kidney disease and in glomerulonephritis, including IgA nephropathy. Gisela, can you see my screen already or no?
Yes, we're good to go.
Okay. About 6 months ago at this point, there were international guidelines put out about IgA nephropathy. People often say, what does KDIGO stand for? Well, it's Kidney Disease Improving Global Outcomes. It's basically international guidelines made by people who study and publish about and read about IgA in order to give guidelines on how to best manage it and how to best understand it.
You're back.
Okay, perfect. All right, I do have disclosures, and then this is going to be our outline for today. So why are we talking about IgAN now? Well, like I said, about 6 months ago, these guidelines were published, and guess what? They're already outdated. There have already been 3 medicines that have been approved for IgA nephropathy after these guidelines were published. So in order to try to make the conversation as relevant as possible for April 2026, I have updated the guidelines, including the 3 new medications. All right, we will make this interactive, like Gisela said. Please feel free to drop a guess down in the chat. True or false? As long as a person suspected of having IgA nephropathy has less than 1 gram of protein in the urine, they are at low risk for kidney failure and don't need a kidney biopsy or medication to suppress the immune system. True or false? I see some answers coming in, and I'm happy to say that you are all correct. So as we're going to see in 2025, we're changing the focus or the belief of IgA nephropathy. It's no longer benign hematuria. It's a significant disease that causes worsening of kidney failure, of kidney disease, and might lead to kidney failure. So on the left, you see the old story. It's just benign hematuria, no big deal. We'll just watch and wait. Don't worry if you can get somebody under 1 gram, they're fine. So just so you know, the new 1.0 is 0.3. Or said another way, 0.3 is the new 1.0. In 2025, we've now changed the story. IgA is a serious disease and many people are at risk of kidney failure. The new strategy is to diagnose and treat earlier with a stronger 2-pronged approach. So again, let's talk about who is at risk of kidney function loss. True or false? The 2025 IgA nephropathy guidelines state that all patients with IgA nephropathy are at risk of progressive kidney failure loss and kidney failure. True or false? I see a lot of guesses, and I don't know if people are joining the crowd or trying to say it. The answer is false. Not everybody with IgA is at risk of kidney failure. And so we're going to try to define who are the people that are at highest risk. Who do we have to treat early and take care of them? So many of you, I'm sure, know this song, but we're going to say, na 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 na, hey, 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 goodbye, 2021 guidelines. It's time for 2025. So once again, on the left is the old way. 1 gram of protein is not low risk. The old way said if you could get them under 1 gram by any means possible, you didn't need a biopsy or immunosuppression because they were at low risk. The new guidelines are teaching us that we need to diagnose earlier and treat harder. Why? Well, this will come up again, but basically, people say to me, Chevalier, what's your goal when you diagnose someone with IgA nephropathy? And the answer is I'm trying to save as much kidney function, as many of these nephrons as I can at the time of diagnosis. Time is kidney function. The earlier we diagnose, the more time there is to save kidney function, the more kidney function there is to save. So now in 2025, we're going to try biopsying anybody with 0.5 gram of protein in the urine and symptoms that may suggest inflammation or glomerulonephritis. We're going to, because we know now that even having these levels that we thought were good, less than 1 gram, still increases the risk over many, many years. We know that many people with IgA are diagnosed in their teens, their 20s, and their 30s. So if they have protein in the urine for years and decades, that slowly eats away at the kidneys and causes damage. Once again, we have the old way on the top and the new way on the bottom. So again, on the left, the old way was you just gave them some supportive care. You would maybe try to get them under 1 gram. And if you did, you were good to go. The new 2025 guidelines say that our goal is to save as much kidney function as we can at the time of diagnosis. So we have a two-prong simultaneous approach. We do the same supportive care at the same time that we're doing the immunosuppression. To some people, this might feel like you're getting more medication than you used to, but the reason is that we want to do an early two-prong attack to save as much kidney function as possible. On the right, once again, you see the old goal of 1 gram. Like I was saying earlier, 0.3 is the new 1.0. KDIGO 2025 suggests you get people under 0.5 gram for a preference under 300. This is significantly more aggressive than we've tried to do in the past, and we'll show you in a minute why we know that this is the right goal. So people often say to me, Chevalier, where did they get this 0.3 grams per day of proteinuria from? Did they just make it up? Is there some rhyme or reason? Well, here's the answer. We know that every human loses a little bit of kidney function every year just by getting older. If you have lots of protein in the urine, you lose kidney function much faster than normal aging. If we get the protein down to 0.3 grams a day, we get people back to normal aging. That's the best we can do. We cannot reverse normal aging. But if we can take someone losing kidney function rapidly and get them back to the normal aging line, that's how we save kidney function and decrease the chance of future dialysis or transplant. All right, what is this 4-hit model? On the left and on the right, we're going to talk about the way that people think about IgA and how we think about the different ways to treat it based on what's causing it. So let's start with the name. IgA is one type of antibody that our body makes. And unfortunately, sometimes people's body make a bad form of this IgA antibody. It's made wrong or galactose deficient. Because these are abnormal antibodies, our own bodies make antibodies to attack it, stick together in clumps. The nephropathy part of IgA nephropathy means damage to the kidneys, specifically the filter called the glomerulus. These clumps of antibodies called immune complexes get stuck in the filter, cause inflammation and eventually permanent damage. Let's look at the 4 hits. These are 4 abnormal steps that must happen in order to get IgA. First and foremost, a person must make these bad galactose deficient IgA antibodies. Number two, the person's own immune system must make antibodies that attack these because they do not look normal. They don't belong there. Because these immune system antibodies attack the galactose deficient IgA antibodies, you make a clump of antibodies called an immune complex. These circulate or travel through the blood until they get stuck in the kidney filter called the glomerulus. This leads to inflammation, scarring, and can lead to permanent damage and eventually kidney failure if not stopped. So, what we're going to see is how medicines or treatments might intervene or affect any of these four or more than one of these four steps. All right, number one. So, something, usually a virus or bacteria, causes our body to make antibodies that can fight the infection. Unfortunately, someone with IgA accidentally makes some of these bad antibodies at the same time they're making antibodies to fight the infection. We all know that certain infections may trigger someone with IgA to have an IgA flare up. And this is what happens. Now, after these bad IgA antibodies are made, the person's own immune system makes antibodies to attack them because they look like they don't belong there. When these antibodies stick to the galactose deficient antibodies, they make these clumps called immune complexes. We're going to talk a little bit more about these blue complements that join on or pile on this immune complex. These immune complexes travel through the bloodstream and, like we said before, get stuck in the kidney filter, the glomerulus, leading to the damage. So just to summarize, galactose deficient antibodies plus the person's own antibodies stick together and along with complement make these immune complexes. And last but not least, number four, these immune complexes travel through the blood. And when they get stuck in the kidney filter glomerulus, it leads to this inflammation. It damages the filter. And things that don't usually get into the urine, like protein and blood, end up in the urine because they break through the filter. And that's why we see urine and blood in the protein, blood and protein in the urine. All right. Why act now instead of waiting? So every IgA nephropathy flare-up is like a punch to the kidneys. True or false? Treating IgA nephropathy when the blood creatinine is normal can save more kidney function than waiting until the blood creatinine gets worse. True or false? Go ahead and make your guesses. So it looks like we have a lot of agreement again. The answer is true. So this is the whole idea behind KDIGO 2025 and early diagnosis. Unfortunately, IgA can be a very silent disease. If all the way over here is when you have 100% kidney function, a lot of times the kidneys are getting worse, worse, worse without many symptoms. This is the point at which we finally do the biopsy and we finally get the diagnosis of IgA. Unfortunately, this is the only time we have left to save these nephrons, to save this kidney function. Well, what our goal is to diagnose earlier. What if we could diagnose all the way back here? That would give us a bigger window opportunity, a longer time period to save more kidneys, more kidney function. And what if we treat more aggressively? Rather than just giving some supportive medicines, we're going to do that two-pronged approach as soon as we diagnose in order to save as much kidney function as possible. So once again, we're going to try to biopsy people who have 500 milligrams a day of protein in the urine when we suspect that they might have glomerulonephritis or an autoimmune disease. This is one of the negative statistics that led to lowering the goal or the threshold to do the biopsy. A study not that long ago showed that 61% of people diagnosed with IgA had a kidney function of less than 60% at the time they had their kidney biopsy. That's not good. If your kidney function is less than 60% out of 100 at the time you're diagnosed, and you're a young person in your teens, 20s, and 30s, you're going to lose a lot of kidney function just through normal aging, not to mention the additional kidney function lost from all the protein in the urine. We want to try to increase this 45% of people that are diagnosed earlier. Maybe we can get this almost normal kidney function up to be like 50, 60, or 70% of the people with IgA. Why are people diagnosed so late? Well, most people are not have no symptoms. They're asymptomatic, and they don't always seek medical care, especially if they have no symptoms. A lot of people with protein and blood in the urine just get told they have an infection and get antibiotics for years. Sometimes people with the blood in the urine are sent to a urologist. They say it's not a urology problem, so you're clear. But that doesn't mean that explains why the blood's in it, blood's in the urine. And a lot of women are told that it's just their period. Come back later, repeat it again. Oh, maybe it was your period again. What can we do? So our electronic medical record system is trying to come up with a system of alerting people that there is protein in blood in the urine, and you should consider referring to nephrology. In many parts of the world, especially Asia, children are screened in grade school looking for blood in the urine. In many countries that have required military service, people going into the military get screened, and if abnormal urinalysis, they get sent for treatment. This is probably cost effective. And in the United States, perhaps we could consider screening at the time of our college physicals in order to catch the blood in the urine and possibly catch the disease at its earliest phases. All right, true or false? In a person with biopsy proven IgA, getting to less than 1 gram of protein in the urine essentially eliminates the risk of kidney failure. True or false? All right, good. I see a lot of consensus once again. So it is false. New data shows that even proteinuria levels that we once considered at goal are actually a really big deal. All right, so like I was saying before, 300 milligrams is the new 1 gram. We know that we want to get people under 500 milligrams a day with under 300 ideally. Once again, that's trying to get people back to normal aging rather than rapid aging from all the protein in the urine. All right, this is the trial that changed the 2025 guidelines. This is the trial that changed the 2025 guidelines. It's called the RADAR study, and it stands for the Registry of Rare Kidney Diseases. I know the letters are in the wrong order, but it's still easy to remember. What was this? It was a registry or a study of looking at the charts of almost 2,300 adults with IgA. At the time of this study, 1 gram of protein was the goal. 1 gram of protein was thought to be low risk for kidney failure in the lifetime. What did this trial show instead? Well, it showed that about 30% of the people that were half a gram to a gram had kidney failure in 15 years. And about 20% who were under half a gram still had kidney failure in 15 years. This is why KDIGO changed the goal. Now, I should make one comment. This trial did try to study the people who are a little sicker and at higher risk. You may know that there are a lot of people with IgA who are lucky and have mild disease. They get a flare up, they get some treatment, and their labs go back completely to normal. Those are those low risk people in the true false question earlier who do not have an increased risk of kidney failure in their lifetime. In order to get into this study where they looked at your chart, you had to have a kidney function of 59 or less, and you had to have at least 500 milligrams of protein in the urine. So these people are not the people that we know have the lowest risk. These are the people that we're worried about that might have kidney failure in their lifetime. Now, once again, this study showed us that losing kidney function every year was terrible. So like I was saying earlier, if you have a lot of protein in the urine, you could lose 3 milliliters per minute per year, about 3% a year of your kidney function. Most people diagnosed between teens, 20s, 30s, they have a 100% chance of kidney failure in their lifetime. That's why we got to get the loss of kidney function even lower. Even people that are losing just 1% per year still had a 40% chance of kidney failure if they were diagnosed under the age of 50. Now, I think a lot of older nephrologists had this benign hematuria concept because the people with IgA they cared for that did end up having kidney failure weren't the patients that they diagnosed. It's the patients that they inherited from the nephrologists who retired. I think we need to stop thinking about the nephrologist's career. If we nephrologists can keep someone off dialysis or transplant during our career, but they still have kidney failure after we retire, that's not a win. The win is to keep someone off dialysis and off kidney failure for their lifetime. Because of this study, KDIGO 2025 recommends that we get the loss of kidney function to less than 1% per year. But you're going to say to me, Chevalier, how do I know what the person's percent kidney function loss is every year? And the answer is, I don't. Even at a first visit, second visit, 1 year, 2 year, it takes years to figure out what percentage of the kidney function is being lost every year. That's why KDIGO tells us everything that we've been saying. Protein in the urine. Protein in the urine. Protein in the urine is what we measure to predict someone's chance of kidney failure. Protein in the urine is what we treat to try to decrease someone's chance of kidney failure. Our goal is to get it less than 500 milligrams with a preference for under 300 milligrams, but ideally as low as possible. All right. Now, one of the biggest complaints about the RADAR trial was that it is done in the United Kingdom, where it was more than 3/4 white people. Fortunately, there was a study done in California that was much more diverse than the RADAR trial, and it showed the exact same thing as the RADAR trial, that after a half a gram, your risk of kidney failure really gets to be a problem. This confirmed that the RADAR trial had it right, and KDIGO chose the correct numbers. All right, let's go on to diagnosing and defining the risk. What is the primary way that doctors confirm a diagnosis of IgA nephropathy? I'll let you read the choices and go ahead and try to answer in the chat. All right, good. So I see a lot of consensus. Everyone's going for a kidney biopsy. I think that a lot of times people are labeled as possibly having IgA just because they have some blood or protein in the urine, but a kidney biopsy is the only thing that proves it. The only true path to diagnosis is a kidney biopsy. All right, so KDIGO 2025 gives us some things that we should do. Number one, we've talked about it several times already. Biopsy people that have 500 milligrams a day of protein in the urine and that you suspect of having glomerulonephritis. After you've diagnosed IgA, make sure there's not a systemic disease to treat that could also cause IgA. We'll talk about this in a second, but everybody gets a report card on their kidney biopsy of how aggressive their IgA is, called the MEST C-score. And then there is a calculation a person can do to figure out your chance of 50% loss of kidney function within like 5 to 7 years. I'm not a huge fan of this, but it is in the guidelines. All right, so what is a MEST C-score? There are 5 letters that should come in this report card of your kidney biopsy. Next to each of those 5 letters will be a number. In general, you add up the numbers next to each of those letters, and the higher the sum of the numbers, the more aggressive the IgA is. I don't think you really need to memorize what each of the letters is for, but maybe you want to remember the E and the C sort of represents active damaging. You're on the clock to get immunosuppression to stop that active damage from the immune system. The S and the T represent permanent dead kidney tissue, scarring. If you don't fix E and C while they're active, they will become S and T. The MEST score without the C started in 2009, and the C was added in 2016. So if someone had their biopsy before one of those 2 dates, you might not have this full report. Once again, 0 is technically the least aggressive, and 7 is technically the most aggressive. Like I was saying, the E and the C, immune system attacking. S and the T, chronic permanent damage. The M can probably go either way. The M does come when the immune system is actively having those immune complexes get stuck in the kidneys, but it also could be like a long-term problem as well. Now, some people think that that bottom line there, when the E and the C is 0, and there's nothing that will respond to the immunosuppression or less so, but the S and the T are positive, that means there's a lot of permanent damage with not much that can be reversed. So once again, this is the report card for your kidney biopsy. 0s are good. 1s and 2s mean more damage. What we're learning from these guidelines is that we are going to use several different objective findings in order to treat to a goal or to tell people their prognosis and aggressiveness. Now, this is that international IgAN prediction tool. It uses demographics, labs, the MEST C score, and blood pressure, and a few other things about medications to sort of estimate a person's chance of 50% loss of kidney function and or kidney failure in the next 5 to 7 years or so. Although this exists and is recommended, I kind of prefer talking about each of the components. Like, we need to control your blood pressure. We need to control the protein in the urine. The MEST C score tells me about the aggressiveness in your prognosis, rather than telling someone the chance that their kidneys are going to be half as bad or half as good in like 5 to 7 years. All right. So what are our goals to treatment? Why is it so low? Why did it go from 1,000 to 300? That seems like a pretty big drop. Well, this is the reason. Most people with IgA are diagnosed young. Even if you have what was previously considered a low level of protein in the urine, it's damaging the kidneys and causing loss of kidney function faster than normal aging over years and decades. We don't want that. We know that if you have more than 500 milligrams of protein in the urine, you're at higher risk for having kidney failure. We need to up the treatment for anyone over 500 milligrams a day. We also do not want to wait for the kidney function, the GFR, to get worse. We want to use the protein in the urine and treat that even before the kidney function gets worse. All right, now this is one of the things in the KDIGO guidelines that I worry doesn't get focused on enough. People jump to the bottom of the guidelines where it's all about the medications, but this is really important. Two-pronged approach at the same time. You are going to do supportive care, trying to close up the holes where the protein's leaking out, controlling blood pressure, drinking water, and avoiding dehydration. At the exact same time, you're doing medicines that suppress the immune system and try to get rid of that galactose deficient IgA. At the time of diagnosis, you want a two-prong simultaneous treatment. No more supportive care by itself for many months. We have to act early and we have to act aggressively. All right. The best optimal care is two-prong simultaneous approach. All right. Which of the following is considered a supportive or foundational treatment for everyone with IgA nephropathy? Go ahead and take a look there and you can take a guess. So I see a lot of good answers. The correct answer is C, optimizing the blood pressure. All right. So I know that people don't love spending as much time on lifestyle, but lifestyle is kind of like a medicine. It's the lifestyle medication. And although it's like actually modifying your lifestyle, this is important in decreasing the stress on the kidneys. So 2 grams of salt a day is a good target. Now, that's about what we recommend for people with heart failure as well. I do have some people I work with who are like, oh, Chevalier, if 2 grams a day of salt is good, then obviously 1 gram of salt a day is better, right? And 500 milligrams a day of salt is even better. But the answer is not really. There is a minimum amount of salt that you need every day in order to function normally. So 2 grams is a nice target. Optimize your weight, please exercise, and quit smoking if you smoke. We're trying to get the blood pressure lower. The top number ideally should probably be in the 110s as long as someone doesn't have symptoms of dizziness, weakness, or lightheadedness. All right, now is everyone's favorite part. We will talk about the medications. On the right side of the chart are the supportive or foundational medicines that can be used for everyone. All right, so number one, ACE inhibitors or ARBs. We have had ACE inhibitors since the 1980s. We know that these medicines lower the blood pressure and decrease the protein in the urine. They are FDA approved to treat people with any kind of kidney disease whatsoever who has protein in the urine, and they can be used with an SGLT2 inhibitor, which is coming up next, another medicine that can lower the protein in the urine and protect the kidneys. A lot of these foundational medicines that we're going to talk about, whether it's ACE or ARB, or it's an SGLT2 inhibitor, or it's going to be sparsentan or atrasentan, they all might make the creatinine go up a little bit. That does not mean the kidneys are weaker. It means the kidneys are working less hard. When the kidneys work less hard, the creatinine might go up a little bit because the kidneys aren't working as hard to clean the blood, but that's good. Kidneys that work a little less hard tend to live longer than kidneys that are trying to function at their maximum capacity. All right, now here's the problem with ACE and ARB. As of March 20th, a research trial was using maximum therapy for IgA at the time. That included blood pressure control, maximum dose of ACE or ARB, and they were allowed to get a statin as well. 45% of the people on this maximum therapy had more than 1 gram of protein a day, and less than a third got to the 500 milligrams. This was the trial that showed us we need more. We need new medications, and luckily we got them. True or false, SGLT2 inhibitors, originally used to treat diabetes, are now recommended for people with IgA nephropathy and protein in the urine, even if they do not have diabetes. True or false? Looks like everybody's doing pretty good. Maybe I should have made the questions a little bit harder, but it is true. So once again, in the guidelines, these SGLT2 inhibitors like dapagliflozin and empagliflozin are recommended to decrease the stress on the kidneys. As you see on the right, they work by making you pee out or making a person pee out salt and sugar to decrease the stress on the kidneys. This is recommended for people with IgA and protein in the urine, whether they have diabetes or not. This will make your urine positive for sugar, glucose, because it's making you pee out sugar. Do not be surprised. This was approved in 2021. All right. It was based on a couple very, very large trials of people with any kind of kidney disease and protein in the urine. Many people with IgA were included in the studies. We should point out that a lot of the people in these trials were older and had worse kidney function than many people in the other IgAN trials, but both the general population and the IgAN population did better with ACE or ARB plus an SGLT2. All right. So supportive medication number 3 is sparsentan. This is also recommended by the KDIGO guidelines. And what they recommend is starting sparsentan or the ACE and ARB, and then adding on the SGLT2. What is sparsentan? Sparsentan is one medicine that does two jobs for double kidney protection. Just like an ACE or ARB, it blocks the angiotensin, but it also blocks another hormone called endothelin. Together, it does sort of double duty. As a note, you do not take your sparsentan in addition to your ACE or ARB. You exchange the ACE or ARB for the sparsentan. So rather than adding another pill to your regimen, you exchange it. This medicine was studied in a trial that showed that it was better than one of the ARBs by itself and lowered protein in the urine a lot more. It did decrease the rate at which the kidneys got worse. And they're one of the few trials that told us how many people got to that 0.3 grams a day, the new KDIGO preferred target. Now, this drug is in a safety program where you have to monitor your labs every 3 months in order to make sure that there's not liver inflammation, because a different medicine that also ends in sentan that was made before sparsentan did have some liver inflammation. So the other medicines in the class are required to have this safety program until they show their safety. All right. This is the first medicine we're going to talk about that was approved after the KDIGO 2025 guidelines were published. It's called atrasentan. So kind of like sparsentan, it also blocks the hormone called endothelin, but it does not block the other hormone, angiotensin. It's important to know this because atrasentan is a medicine that you add on to your ACE or ARB. So you'll take the ACE or ARB you're taking plus atrasentan. You don't exchange the ACE or ARB for atrasentan like we saw on the previous slide with sparsentan. This was also studied in a large trial, and it also lowered the proteinuria. They just sort of published their 2-year data. This medicine currently has accelerated approval based on their 9-month protein in the urine data and should have their full approval in the future. They do not have a safety program right now because they also had another trial that they studied the medicine in diabetics, which also had some patient safety data to allow them to have enough total patients treated with the medicine to not need the safety program like other medicines that end in sentan. All right, so now we're going to shift gears a little bit. We're going to talk about that inflammation. In the autoimmune diseases, it's not always that antibody, it's the inflammation that's caused. So let's go back to hit number 4 in our 4-hit hypothesis or our 4-hit model. Those immune complexes get stuck, and that's what causes the inflammation. If we don't stop that inflammation, it leads to permanent damage and scarring, which can eventually cause kidney failure if we don't stop it. Now, as I think you remember, we talked a little bit about how there is a complement in those immune complexes. Well, on the left there, we have a picture of a kidney biopsy. What that biopsy shows is some of the antibodies that are seen in someone who has IgA. For decades, we've talked only about the IgA because that's what gave us the diagnosis. We never really talked about the C3 complement or the IgG antibodies that are also in the same place. But now that we have treatments that could treat this part of the mechanism of action of IgA, we're talking about it a lot more. So what is this complement? Well, over here, it's mostly these like rods that we're going to call them. They float through the bloodstream in their inactive state. We don't talk as much about them, but they are certainly part of the immune system. When they come into contact with a bacteria or even with antibodies, they start this cascade like a snowball effect that starts to cause inflammation in order to get rid of the bacteria or the immune complex or things that shouldn't be there. So, if this is the complement, what happens when it gets activated is it splits into one piece that calls in more cells for help. So, it goes and signals for help. And the other half of this molecule turns into something that drills a hole into the bacteria so that the bacteria bleeds to death and dies. So, our complement helps us very much to fight certain infections that have a thick wall on the bacteria. A little complement is active all the time, but when the complement gets out of control, that's when diseases can happen. All right, so once again, complement kind of comes in and attacks these immune complexes. Once again, part of it goes and signals and calls for help, and the other part makes a hole which helps it to bleed to death. Even though this happens in the bloodstream, a lot of this happens where the complement attacks these immune complexes that are stuck in the glomerulus. This leads to this inflammation, even more inflammation, which could lead to permanent damage, death of the kidney cells, and eventually kidney failure if not stopped. So, the next medicine that we're going to talk about that was approved after the KDIGO guidelines were published is iptacopan. Now, I still think that iptacopan is something that a lot of the nephrology community is trying to figure out exactly how to use. When it first came out, many people talked about how it worked on HIT4 in terms of trying to block the complement from attacking these immune complexes stuck in the kidneys. But I also think that it might block the immune complexes the complement trying to attack the immune complexes in the blood. So is it possible that it could be both an immune modulator or suppressant that gets rid of some of these immune complexes as well as something that works on inflammation? This was studied in another large trial. Once again, it has its 9-month proteinuria data and has accelerated approval. It should also get its full approval based on the 2-year data soon. This medication is also in a safety program. It requires vaccination against certain bacteria that have that thick cell wall, which is usually the ones that complement kills. So if complement is being inhibited, you need to be vaccinated against some of those. All right, but Chevalier, what is your exact regimen? So because of medical insurance that requires me to use the older medicines first, I usually start an ACE or an ARB. If medical insurance wasn't an issue, I probably would use the dual-acting sparsentan first. But that being said, I often start an ARB because it has fewer side effects than ACE. I add the SGLT2 if they're not under 500 at least. So now they're on these two medicines. And if they're still not at goal, I exchange the sparsentan for the ARB and continue on the SGLT2. At the same time, I'm using whatever other blood pressure medicines I need to try to control the blood pressure. All right, now we're going to switch to the left side and talk about medicines that suppress the immune system. All right, number one, or maybe in general, this is prong 2, where we're going to lower the galactose deficient IgA by blocking the immune system at one of those three steps or more than one of those three steps to prevent the bad IgA antibodies from getting to the kidney filter. Now, the only two medicines which were in the KDIGO guidelines at the time of the publishing of the guidelines were two of the steroids. The first is one that's called budesonide or Nefecon. What this medicine is marketed to do is to target some of the lymph nodes that are in the gut, which are believed to and sometimes have been shown to be found in the kidney biopsies of animals and people with IgA. So the hope is that this will calm down the immune system to make less of the galactose deficient IgA. They had a trial that showed that they decreased the antibodies and decreased the protein. And over 2 years, they slowed down the GFR loss. So they have full approval to treat IgA. One of the practice points in the guidelines is that these steroids do not cure IgA with one course. Just like the systemic steroids that have been used for decades, one course does not always cure or control IgA because of flare-ups that may come back. There is a lot of debate about how many side effects you get from this targeted budesonide. My opinion, based on my evaluation of the literature and my experience with patients, is that a lot of the systemic side effects seen with systemic steroids are also seen with this medication. All right, the other medicine recommended by KDIGO is the systemic steroids. These are medicines like prednisone or methylprednisolone that we have been using for 40 or 50 or more years. I think they get a little bit of a worse rap than they deserve. Nobody, no practicing nephrologist gives some of the doses that were done in the earlier studies. So the high doses that were given gave a lot of side effects. No practicing nephrologist would ever give the doses in those early trials. The lower doses of these steroids still had good outcomes with a lot fewer side effects. And I often use this lower dose protocol and get good results with low levels of side effects. Unfortunately, a lot of the trials and research and companies that compare their information compare it to these very old trials using the original doses that haven't been used for years. All right, what is April? April is more than just the fourth month of the year. April is a chemical or a hormone, just like BAFF. So we have started to get new medications that can lower the galactose deficient IgA antibodies and lower the protein in the urine. Currently, we have an FDA approved medicine that blocks the APRIL hormone. There are medicines that block APRIL and BAFF in development and might be FDA approved as soon as later in 2026. There might also be some antibodies, some medications that directly attack the plasma cells themselves. All right, so what exactly are they? APRIL stands for A proliferation inducing ligand. BAFF stands for B cell activating factor. The cells that actually make both the bad IgA antibodies and our own immune system antibodies are the plasma cells. APRIL works more on blocking the plasma cells. BAFF works more on blocking the B cells. Both APRIL and BAFF are higher in people who have IgA nephropathy and get higher when the disease is more active. Where did they come up with this APRIL and BAFF, Chevalier? Well, the answer is They started with tens of thousands of people who have IgA, and they looked at their genetics. APRIL was one of the genes that was mutated. The receptor called TACI for both APRIL and BAFF was also mutated. Because this was mutated and the levels of these two hormones are higher in people with IgA and higher when a flare up is happening, researchers and pharmaceutical companies looked at these for potential uh, hormones to block in order to help IgA. If we block if we block the hormones that are helping plasma cells to make antibodies, are we worried that they might increase the risk of infections? Well, it turns out that all of these medicines that block APRIL and BAFF, or APRIL plus BAFF, they were done during the COVID pandemic. And luckily, we did not see a lot of increased infection risk compared to the placebo group. All right, so once again, APRIL works on the plasma cells. BAFF works mostly on the B cells. There is some overlap between the two. This could happen in the lymph nodes or in the bloodstream. I've been calling BAFF and APRIL these live long and prosper cells. If BAFF is blocked, it will block the B cells from living long and prospering. If APRIL is blocked, it will block the plasma cells from living long and prospering. Why is that important? Well, usually a plasma cell should make the good antibodies to fight an infection. When the infection is gone, the plasma cells should stop making antibodies and go away. But if there's too much APRIL around, it keeps these plasma cells making antibodies too long. And unfortunately, it keeps the galactose deficient IgA plasma cells making antibodies and living too long. Like I was saying, these medicines lower the plasma cells that make the galactose deficient IgA, but also lower the plasma cells or block the plasma cells that make the normal antibodies. So, like we were thinking, there might be a risk of infection, but so far it doesn't look like it compared to the placebo group. And the potential is that by doing this, we might be able to treat other autoimmune diseases where antibodies are the problem. All right, so here is our last medicine that was approved after the KDIGO guidelines were published. The name of the medication is called sibeprenlimab. Sibeprenlimab is a medicine that blocks APRIL and stops the plasma cells from living too long. It's a shot that you give yourself into the fat every 4 weeks. It lowers the bad antibodies and lowers the protein in the urine. You can see the levels there. It lowers the protein in the urine. And at 12 months, 34%, 1/3 of the people that got the sibeprenlimab got to the KDIGO guidelines of less than half a gram of protein in the urine. This is the first medication in this APRIL and BAFF blocking class, which we're calling B cell modulators. Because this medicine affects the immune system and appears to have few side effects and lowers the galactose deficient IgA and protein so much, it's possible that people might not need the steroid medicines with their potential side effects in the future, and that we might have an alternative for them. All right, so what are the things that are in process? So at the bottom of my updated 2025 guidelines, I've added some of the medicines that are currently in research trials. The first thing I have to point out is that even though sibeprenlimab, an APRIL-only inhibitor, is effective in treating IgA and lowers the bad IgA and lowers the protein in the urine, BAFF-only inhibitors do not work. 2 medications that block only BAFF lowered the protein so little that they did not move from a phase 2 to a phase 3 trial. Now, there is one more medicine that's APRIL-only blocker that's in production. The name of the medication is called zigakibart, and it's a shot given every 2 weeks. We're waiting for some of the early data. There are a few medications, 3 specifically, that block both APRIL and BAFF. 2 of these medicines have a possibility of being approved by the FDA later this year. So far, they have published some of their data, and they also lower the protein in the urine and the galactose deficient IgA, similar to what the APRIL-only inhibitor sibeprenlimab did. All right, so this is a question I get asked pretty much every week. Is BAFF important, or is APRIL the important part? Well, what do we know? We know that a BAFF-only inhibitor does not work. We know that an APRIL-only inhibitor does work. We know that the gene for APRIL was mutated in people with IgA. The gene for BAFF was not. However, the TACI gene, which is the receptor for both APRIL and BAFF, was mutated. In the 3 phase 3 trial data that we have so far, the APRIL-only inhibitor lowered the protein in the urine nearly identical to the APRIL and BAFF inhibitor. We know that the KDIGO guidelines talk about lowering the protein in the urine. Now, a lot of the people who support or believe in blocking both APRIL and BAFF are telling us that we need to wait. We need to see what the long-term data says. Other people are like, look, that's what your parents say when they say, because I said so. That's not really an answer. We're waiting for 12-month data. We're waiting for 24-month data. But as of the 9-month data, the results look very similar for every medicine in that B-cell modulator class. All right. There are plasma cell antibodies that are in development. These medications would target the plasma cells directly. They're further behind in their development, and they probably will not be available for a few years. All right, there also are other medicines that block the complement, and they are also in development. Again, they're probably going to be a few more years before they are available. All right, let's put it all together. So let's say somebody is 35, they have above goal blood pressure, the GFR 70, you can see their MEST C score, and they have 1.8 grams of protein per day. So the old way is that you would give them an ACE or ARB, try to increase it over 6 months, wait maybe a year. They come down a little bit, but what are you going to do? There's no guidelines. Should we give them some steroids? Should we do a biopsy? Maybe. Nowadays, we're going to be more aggressive. You start either the ARB or the sparsentan, and you add a medicine to lower the galactose deficient IgA at the same time, at the time of diagnosis. You try to get the medicines to the maximum dose. If the supportive medicines have not gotten the protein to goal, you add the SGLT2. You can exchange sparsentan for the ARB if you haven't already done that and continue the SGLT2, good blood pressure control, and eventually you get the protein to goal. This is what we're talking about early diagnosis, aggressive combination 2-prong treatment to get to the goals quickly. So one final chart here. The vibe of IgA used to be benign hematuria, no big deal. Now we know it's a serious disease that causes kidney failure in a large number of people. The old way was like, yeah, just get them under a gram. Don't worry, a gram. Now we're going to biopsy if we see 500 milligrams and we suspect glomerulonephritis. No more is it 1 gram. Think of 0.3 as the new 1 gram. No more supportive care first. It's simultaneous 2-pronged approach with supportive meds and immunosuppressive meds together. No more watch and wait. We're going to treat aggressively to get to target. All right. Now, I don't love using brand names in a talk like this. However, I received dozens of requests to use the brand names so that people understand, because those are the medication names that people see advertised and are familiar with, especially if they're uh, prescribed one of these medicines. So go ahead. Which of these FDA approved IgA nephropathy medicines is a steroid that targets the lymph nodes of the gut? A, B, C, D, E. So excellent. It looks like everybody's got E. Number 2, which of these FDA approved IgA nephropathy medications is a supportive foundational medicine that's exchanged with an ACE or ARB to lower the protein in the urine? A, B, C, D, E. So the answer is actually C. D is not exchanged. D is added on to. C is the only one that's exchanged for the ACE or ARB. All right, which of these FDA-approved IgA nephropathy medicines is a complement inhibitor that requires vaccinations before starting? A, B, C, D, or E? All right, it looks like everybody was paying attention. The correct answer is, in fact, A. All right, which of these FDA-approved IgA nephropathy medicines is a supportive or foundational medicine that is added onto an ACE or ARB to lower protein in the urine? Everyone is correct again. This must be D. And I know there's only one left, but which of these FDA-approved IgA nephropathy medicines is an APRIL inhibitor that lowers galactose-deficient IgA and protein in the urine? So yes, the only one that is left is letter B. All right, so this is kind of like my final slide. This is basically a summary of the 2025 guidelines. Diagnose earlier, treat earlier. The earlier you diagnose, the more kidney there is left to save. The more aggressive you treat with the two-pronged approach, the better your chances are of saving the kidney that's alive at the time of biopsy. We are now trying to get people under 500 milligrams of protein with a preference for under 300 milligrams. As soon as we diagnose, we want that two-prong treatment, two-prong attack with both supportive medicines and the IgAN specific medicines that lower the galactose deficient IgA. Long term, this is a this is a disease of decades. We want to make strong and aggressive treatment choices now to help people's kidneys 10, 20, 30, 40, 50 years from now. All right. I hope you all enjoyed it. I do want to thank Bonnie and David from the National Kidney Foundation. They helped with a lot of feedback on creating slides. And Dr. Salvatore gave me the picture of the kidney biopsy. If you want to see a doctor or help, just let me know. We're happy to hook you up. At this point, I'm more than happy to take any questions if people wanted to ask a question about the medicines or the guidelines or anything.
I think that was a great presentation, as always. I'm
Oh, thank you.
jealous that you were not my doctor 30 years ago, but we didn't know this much 30 years ago. But I think that's one of the things that's really exciting is I know it doesn't feel like it sometimes, but like we know a lot more today than we did yesterday. And I think you did a great job of explaining that with how quick the guidelines change and really calling everything out. This is super informative. All right, we're getting people were shy first. They were like, let me
So
see
if
who's gonna say A, B, C, D.
So if someone's urine protein levels vary every few months from 300 to 1,000, how do you interpret those results? Well, things that can make the protein go up and down, like on a daily basis or even hourly basis, when the blood pressure goes up, the protein in the urine goes up. If you exercise or if you take Advil, leave ibuprofen, Motrin that you're not supposed to, or if you have a super high protein meal, you might
Hmm.
see a little bit more protein in the urine. But by far the most common cause is the blood pressure going up. I would consider trying a little bit more therapy if you're regularly over 300 milligrams and see if you can be more consistently under 500. There's no guidelines yet on when to do additional biopsies after the initial diagnosis. I think most people, myself included, use the blood and protein in the urine to recognize or diagnose a flare up. One of the most controversial things about IgA right now is whether blood in the urine means inflammation and activity of the immune system. I'm with the nephrologists who say yes. I think that, well, we know that people who have chronic microscopic hematuria do worse than people who don't have blood in the urine microscopically for years. I think that probably represents a little bit of immune system activity. Those are the people that I'm more likely to give immunosuppression for. And now that we have medicines that are not steroids, like these APRIL inhibitors, I feel a little bit more comfortable giving it. After transplant, do we look at the same treatment setup? So I want to be very honest. These medicines were not specifically studied in people with a kidney transplant. I am going to give my own opinion to your question. I believe that these medicines would work just the same in IgA after a kidney transplant. They are being used in people with IgA and a kidney transplant. It's nearly 100% recurrence of IgA in a kidney transplant. But because you're taking the anti rejection medicines, that partially treats IgA. If you break through your transplant medicines and have sort of IgA flare ups on top of that, some of these other medicines, like the supportive medicines, have been great at trying to get the protein down. And there are people that are using some of those immunosuppressive medicines that we mentioned in transplant patients. MSC score of 0. So the short answer is I do not use a lot of stepping it up a notch if someone's under 300 milligrams of protein. So if I have somebody who starts an ARB, like let's say losartan, and their protein in the urine gets under 300, I would not add on the SGLT2 and I would not add on or exchange for sparsentan or atrasentan. I think that they've got to go on the medicines that they were taking. Now there are some people that would try to get them down to like 100 or 50 or 30. So I do have that conversation with people about whether or not they want to continue to try to get it lower, although it might give side effects as well. I feel like I'm going to be a little bit easier to give the APRIL inhibitors more than I was willing to give these high doses of steroids in the past. Uh, so the payers, the medical insurance companies, I have my experience has been I can usually get these newer medications, but a lot of the insurance companies are making patients fail some of the older and cheaper medicines first. So a lot of insurance companies have made patients fail an ACE inhibitor ARB before getting sparsentan, a lot or atrasentan, and a lot of patients have had to fail steroids before getting the sibeprenlimab, the APRIL inhibitor. I don't believe that's scientifically based. I believe that's financially based, which is unfortunate. Is there a limit to which the people? So there are some people who would let the blood pressure go lower than 115, for example. There are some people who like lowering the blood pressure until the patient almost gets dizzy and falls over. I do not agree with that. I think that there's a minimum amount of pressure needed to pump the blood through the kidneys for the kidneys to clean the blood. So I like the 115 goal. Um, I do think that the APRIL inhibitor is going to be a good choice for people who have this chronic microscopic hematuria, for sure. But even in the people that didn't have blood in the urine, the APRIL inhibitor still worked. So I've used the APRIL inhibitor in about a dozen people at this point who had protein in the urine despite trying everything that had been FDA approved up until that point. The people who had active flare ups with blood in the urine had a very fast decrease in their proteinuria. The people who had no blood for years in the urine seem to be having a slower decrease, but steady decrease of the protein in the urine. So I do think that it is easier and faster to treat inflammation than it is to treat just scarring. Heavy lifting or straining during exercise is usually okay if it's a temporary raise in the blood pressure. In general, we don't recommend always going for your 1 rep max. We usually prefer like 5 sets of, 3 sets of 10 or something like that, rather than your 1 rep max. So I would consider that as a weight training regimen so that you don't get your blood pressure too crazy all at once. Consider a little bit lighter weight for more reps rather than always trying to get your 1 rep max. So I think that if you have a lot of protein in the urine and you're over 500, KDIGO guidelines and my recommendation is to take more treatment that you're currently taking if you're not already maximized. If you're at 1,000, you should be taking more treatment than what you're getting right now. The only exceptions to that is the people, like I was saying, who had tried everything. They were on the Filspari, the Iptacopan, the SGLT2. They had tried Tarpeo. They had tried prednisone. And so when the sibeprenlimab came out, that's when I'm sorry I said the brand name, budesonide. When the new medicine sibeprenlimab came out, that's the people that tried it right away. But prior to a new medicine being available, if they were already on the maximum dose, nothing else to do. But if someone's not on the maximum dose, I would increase the treatment. Um, so the short answer about the blood and urine samples is we don't know. The longer answer is if you're a teenager or anyone who has not finished going through puberty, we recommend doing first urine sample of the morning. It is true that in somebody who's still growing, the filter, the glomerulus is stretching a little bit. So when you stand up, you might get some protein in the urine just from the stretch of your filter growing through puberty. When you're lying down flat, you don't get as much of that effect. So that's why in people who haven't finished puberty, we usually take the first morning sample. If you're an adult, I don't think it's not as quite as much of a requirement to do it exactly the same time. I like the idea of trying to do it under as similar conditions as possible. If you're fasting, I do think you should drink plenty of water. You always can have water before a blood draw what's fasting. So don't worry about drinking water before the fasting bloods. So somebody asked about 3 grams. You might be thinking 300 milligrams. If it's 300 milligrams, then I'm hoping, oh, there's a point. I'm sorry, there's a 0.3 there. So if you get under 0.3, the question becomes, do you and your doctor want to do an experiment of stopping or lowering the amount of medicines you're taking and see if you can stay under the 0.3 grams or the 300 milligrams a day? Uh, we know that many people with IgA heal. Their immune system stops attacking their kidneys and their tests get better. So there are people, many of the people that I work with, that over time, if they have good labs, we have a discussion of the pros and cons of decreasing and eventually stopping meds to see if they stay at goal on less or no medications. I don't think there's any problem using a cold plunge with a sauna. I don't know of any damage that can be done to the kidneys with that. Um, so the urine protein 24-hour collection is really hard to do. I prefer using that urine protein to creatinine ratio because you can do it on a random sample and it's easier. You might have noticed that in some of the slides, there's a slightly different number. depending on when you use that, for whether you use the protein to creatinine or the 24-hour collection. The 24-hour collection numbers are a little higher. So if you say 1 gram of protein a day, it's about 0.88 on a protein to creatinine ratio equals a gram a day on a 24-hour collection. That being said, I don't think it's that important that you really needed to convert it. I think you can just ballpark it the same way. I thought the question that somebody was going to ask was whether I use the albumin to creatinine ratio or the protein to creatinine ratio. Most of these research trials used the protein to creatinine ratio, but many of you in the audience probably know that it's the albumin that represents the damage to the kidney filter. Other proteins could be excreted or filtered appropriately or inappropriately and be in the urine. So I prefer to use the albumin to creatinine ratio, which is a better marker of damage to the filter.
That actually is a question further down, so
Oh, it
you're
is.
ahead of
Okay.
it.
So when it comes to IgA, I don't know if there's any definitely premature rupture of membranes associated with IgA specifically. It depends. For pregnancy, they actually do make recommendations in the guidelines that I thought were just a little bit too long for this talk. You want to get off ACE, ARB, SGLT2, sparsentan. You probably don't want to take the immunosuppression, but it is possible if you need it. In general, if a woman has more than 1,000 milligrams of protein or a creatinine of 2.0 or higher, that's sort of the limit of us recommending a pregnancy. The reason is that the risk of miscarriages or birth defects or worsening kidney function is pretty high, like 30% or more, if you have more than a gram of protein in the urine and or a creatinine of 2 or higher. Oh, somebody did ask about the albumin. Okay. Can we take the April even under 0.3? The short answer is I don't think it would hurt you, but I'm not sure that it would help you either. So I'm not sure that most doctors would give you an April inhibitor if you were already sort of at the KDIGO guidelines goal. If you have more than 3,000 of protein in the day, I think you should work on maximizing all of those supportive medicines that we mentioned and maybe talk to your doctor about adding one of the galactose deficient IgA lowering medicines like the APRIL inhibitor. I think that the APRIL inhibitor is a great replacement for what you mentioned, the brand name of budesonide called Tarpeo. My observation is that the people that I've seen that have been taking that budesonide have had all the side effects of systemic steroids. They've had acne, they've had high blood pressure, they've had weight gain, they've had fluid retention. I think that this sibeprenlimab, this APRIL inhibitor, is going to revolutionize IgA and get rid of a lot of the side effects that patients have been suffering with for years and decades. I think that the GLP-1s definitely work in diabetic nephropathy. I suspect that they work in kidney disease with protein in the urine, like IgA, but there is not yet proof or data to show that. I think there's some unpublished information that people who do not have diabetes or obesity could benefit from a GLP-1. People that are obese or have diabetes do get kidney protection from improving diabetes and obesity, which are two of the biggest contributors to kidney disease. So some of the diseases that we rule out after we diagnose IgA to make sure you don't have a systemic disease causing IgA, some of the liver diseases, some of the skin rashes or viruses, some of the most common are Crohn's disease or ulcerative colitis that are associated with IgA. Some of the autoimmune diseases like rheumatoid arthritis could have IgA. Sometimes HIV could lead to IgA. If you have one of those systemic diseases, in addition to some of the supportive therapies, you might use immunosuppression, but you would definitely treat the systemic disease. So I've always wondered if the strength of C3 positivity on the kidney biopsy would be a reason to choose the iptacopan first. There are pathologists who believe that's a true statement. I also might have been saying earlier, I think that the nephrology world kind of lumped iptacopan into the like supportive, like sparsentan and ACE and ARB category, but I do think that it has value as preventing the immune complexes and some of the immune system issues. Now, if you're asking if it's on the kidney biopsy, you're sort of asking about that HIT4 and the inflammation. I've actually had a little more success with using the iptacopan as an immunosuppression more than as an add-on to like the Filspari, excuse me, to the sparsentan plus ARB, or excuse me, sparsentan plus SGLT2 plus iptacopan. For me, didn't do as well as when I was using iptacopan on the immunosuppression side. But I don't think anyone's ever been able to prove that a strong C3 staining on biopsy equals good outcomes with iptacopan. But scientifically, it makes sense.
I think we need to do Ask Me Anything with you on Reddit or X. I think people would love that. We might have to figure out a plan for that. I think I want to be mindful of everyone's time. I see two more questions in here and we'll wrap up quickly if that's okay with you,
Okay,
Dr.
sure.
Chevalier.
So I have noticed myself that the SGLT2s sometimes do not lower the protein in some people. Now, I don't know if that's the case for the person that asked the question. It's also possible that the scarring could have progressed. So sometimes the disease continues to cause more scarring and cause more protein in the urine, even when you're adding medicines. And the last thing that could raise the protein is the blood pressure. Anybody who has a higher blood pressure will definitely have more protein in the urine. So if your blood pressure top number is not in the 110s, you might want to make sure that it is to try and get the protein in your urine down. So the last question asked about combination immunosuppression. So just for the record, no studies have ever been done with combination immunosuppression at this point. I have felt comfortable using iptacopan sometimes in people who had recently received steroids, for example. I've never actually teamed up an APRIL inhibitor with any of the other medicines that are also immunosuppression. They're certainly not FDA approved that way. I suspect that in the future, let's say the 2030 guidelines, it's probably going to be a combination of one of those APRIL inhibitor type medicines plus the like say sparsentan plus SGLT2 all at once as the start, and then you may or may not add on things to that once you have that foundation if you don't get to goal.
Thank you. Everyone, Dr. Chevalier will be at Spark this year. He's actually going to be helping us with two sessions, and we're so excited to have him live. We'll be going over IgA nephropathy basics, and then we're also going to talk a little bit about post-transplant. So I'm excited for that because I am post-transplant. We know a lot of people also worry about that. But thank you so much. This has been great, really informative. I learned a lot, and I also appreciate some very creative illustrative slides as the brand director. I think they were great. Some of the best slides. I think we have to give we're giving you some applause here because those are some of the best slides I've seen in a long time.
Oh,
So
thank you.
really great. Thank you so much. Everyone will receive a copy of this recording. And again, if you have any other questions, please feel free to reach out. And we hope to see some of you in person at Spark this summer. All right, take care. Thank you, everyone.